Welcome to Startup Health TV, where we celebrate the entrepreneurs and innovators who are transforming health. I'm your host, Logan Plaster. It's my privilege to be here today with Mark Clermont, CEO of Cecelia Health. Mark, always good to see you.
Yeah, fantastic to be here. Thanks, Logan.
So, love what you're doing. Love how you have combined technology with the human touch to really scale care, initially for diabetes, but now with a host of chronic care conditions. So just level set with our viewers what Cecelia Health is in 2023.
Yeah, so we've been talking for years about how access to specialty care is limited. Just there aren't enough specialists. People have a hard time accessing healthcare to begin with, let alone when you need to get referred to specialists. Half of all patient encounters in the U.S. are with a specialist.
Yeah.
So we have this conundrum, and meanwhile we mentioned we started with diabetes. It's increasing in prevalence, so more people need help. It's just a complex problem. And so our job is to be here modernizing so we're a virtual specialty medical practice. We're modernizing the specialty practice, much in the way that primary care has already started modernizing. You think about some of the virtual primary care players that are all common names, One Medical, Oak Street,
Yep.
Carbon, you name it. When they refer to a specialist, things go off the rails.
It goes back 10 years or 20 years?
Well, so I liken it to, for me, the experience with one of these new VPCs is fantastic. It's like the first time I saw a high-definition TV.
Yeah.
And then you get sent to a specialist, and it's like you're sent back to the low-def TV days,
Yeah.
and come on.
And you're like, guys, didn't you see over here that there's a new technology available?
And that first moment you saw an HD TV, you said, I'm never going back. You replaced all your TVs immediately. So, why should the specialist experience be like that?
Yeah.
So one, we're modernizing it. And what that means is we're working with the patient in the same modernized way that they experience with their primary care, meaning we're always on. We're accessible.
Yeah.
If you want an appointment, you're going to get an appointment, and it's going to be timely. It's not going to be 6 months from now.
Easy scheduling, online scheduling.
And what that means for primary care, who, by the way, primary care, they've got a tough job. It's getting harder. There's more demand put on them, more patients coming to them, more documentation requirements. More data. How do you process all that? There's new drugs coming online, new treatment protocols, you name it. All these things. You have to keep track of a lot. And meanwhile, you aren't necessarily getting all the data streams for your patient that keep you informed. And boy, how frustrating is it when you make a referral to a specialist and it's basically, to you, it looks like a black hole. You don't know if your patient has actually gone to see the specialist, when. Sometimes it's, again, access problems, so it could be 6 months from now, let alone understanding what that care plan might be. And what if there's a level of coordination that's required? What if that...
Which, of course, there should be this back and flow, this flow of information and care.
Absolutely. And it's possible. And so this is exactly what we're doing. So when we talk about modernizing specialist care, it's not just about modernizing how patients interact with their specialist, how they access us, improving all of that, put it on the same plane with all of those great actors that are out there today. But we're also talking to them in a modern way. Yeah. And so we're exchanging data, we're exchanging care plans, we're making sure that they are informed that their patient is cared for in the manner that you intended when you made the specialist referral to begin with. And they love it. So it's completely transformative in that way. And so I'm really excited about that.
Nice.
So here we are, again, modernizing specialty practice, but we're doing this in a multi-conditioned way. So we started with diabetes, and of course we migrated, we talked about this last time, into cardiovascular. We're in pulmonology, nephrology now. Again, all in the spectrum of chronic conditions. And you have this overlay of mental health, emotional support, but this overlay of obesity. And so there's this new, it's now caught fire in the press, but we saw it coming along, all these GLP-1 drugs. They fit in a class called anti-obesity medications. And so we've worked with weight management obesity all these years because there's an overlap with diabetes, there's an overlap with cardiovascular.
What's your macro perspective on these therapies in general?
Well, it's a fantastic and transformative drug class. So again, we've been working with this both in R&D and in the commercial space for years and years. And so we see the benefits of these drugs. People are losing weight, they're controlling their sugars. Most of these drugs are born out of diabetes. So we understand what that means as you have these comorbidities. But at the same time, we're seeing a scary thing, is that because it's getting so much publicity, that how effective these drugs are for weight loss, we're seeing a lot of fire take hold where patients are now getting access to these drugs without the level of clinical support that they really
that specialist
deserve.
care you're talking about.
Well, that's right. That's right. And so, and the unfortunate thing is these drugs are new. They're newer as a drug class. They've been around a long time, but they're newer. It's not like statins that have been around for 40 years and they're well understood. They're not like some of the other drugs that you might go to for a direct-to-consumer online prescription that are well understood, been around for 40, 50 years. Standard of care is well defined. The indications and all the complexities of other drugs, understanding the drug interactions, everything. So these drugs have a lot of emerging side. They have emerging understanding in the medical space, and so we're looking at this and we're saying, well, look, we're seeing this consumer demand for these drugs. They're very expensive. That's what everybody talks about, how expensive they are. They also juxtapose that with how effective they are, and at the same time, what do you do about that? And so people are jumping on it, and so we're seeing this actually dangerous scenario starting to emerge, and that is that patients aren't getting appropriateness of care. Mayo had come out with had published a report that 5% of patients that are going onto a GLP-1 show up with severe dehydration in the ER because they're not getting any kind of support.
Yeah.
And you say, well, where do those patients get their drugs? They might have gotten it from their local med spa. They might have gotten it through one of the online houses. These are, not to take away from the effectiveness, what these parties do, but you've got to be careful to be a practice of medicine and not just a practice of prescribing.
Interesting.
And that's the kind of the dangerous scenario here. These drugs are not, again, there's a lot of emerging effects that are, and positive effects, but let's understand what the standard of care is.
So break down for me then what the Cecelia Health model would be in terms of providing that specialty virtual clinic for obesity.
Yes, so one, generally people with obesity might have other comorbidities, right? And oftentimes it's some form of diabetes, cardiovascular, et cetera. So one, you don't want to be just affiliated with someone who only treats obesity and is interested in being a pill mill.
Yeah.
That's a very dangerous situation. By the way, the pharma companies don't want that either.
Okay.
A lot of people give, maybe pharma gets a bad rap for that kind of thing, but actually they care about patient safety a lot. And they care about appropriateness of care as well. They know the efficacy of these drugs as long as they have the right kind of supervision, right? So one is when it comes to these again, we refer to them as anti-obesity medications because GLP-1 is only one of many that fit within that construct. One, you've got to be, this is a strange time. They're not well covered under insurance. They do have a higher cost. The cost equation is not well understood. And so for example, you might have people look at, well, they cost $1,200 a month. And what did I get within my plan year, my 12-month plan year for a benefit in terms of beneficial side effects for my patient, for this member?
It's just early,
Which is early, but maybe you're not taking into account that the patients now cut back on their food intake. And there's probably food savings for them, food cost savings of about between $5,000 and $6,000 a year. So those don't necessarily enter into the equation sometimes in the analysis. And again, so you're going to need to look at all of these things. So you look at appropriateness of care. Is this actually clinically warranted for a patient? And if it is, let's then provide an access for a pathway for access. Let me give you one stat.
Sure.
So we were working with a patient panel of 85,000 new patients that were provided to us from one of our partners, a retail healthcare practice. Of that 85,000, what we found as we were enriching this data, because we're a provider, because we've invested heavily in the trusted exchange framework, and that's giving us a very powerful viewpoint into where a patient's real clinical profile is. What we found is over 20,000 of that 85,000, that drug actually wasn't indicated for them. And you can go on all the other aspects of, well, how did they get the access then if that was the case? And that's a fine question for someone else to answer. What we care about is the appropriateness of care. And so that's a big percent. And you could extrapolate that out at a population level, and that's a lot of potentially inappropriate care.
Yeah.
At the same time, what we saw is in this 85,000 patient panel, there was a group that was not actually on the drug that should be, for which it was indicated. I shouldn't say should be, but it was indicated, and so should have a patient clinician consult and understand whether this is appropriateness of care for them. So it's just a complex problem. There are a lot of people talking about it. There are a lot of demand from patients. There's a high cost equation for insurers, a high cost equation for employers. Employers actually are at the forefront of trying to change and adapt to how do we make this happen. And we all need a collective recognition that while there's a high drug cost right now, that's not a permanent state. As these drugs are starting to take hold, as the years will start ticking off and Medicare perhaps starts covering this in 25, 26, 27, whatever year that becomes, the cost of these are going to come down. Meanwhile, there are some entities like us that are moving the dial forward in terms of understanding what should be the standard of care.
Got it.
What's the emerging evidence? How do you modulate your practice? And you look at that from a patient safety standpoint. If you're an employer, one, you know that you need to do this. You need to be mindful of what's happening with this drug class. Whether you want to cover it or not, your patients are taking it.
Yeah.
Your employees are taking it, or the dependents are taking it. They're the ones who are showing up in your ER, and you're paying that cost.
Yep.
So you have to do something,
Yep.
and you can't just put that one off. And so it's good. It's really actually refreshing to see that employers, many of them, are at the forefront of this, and pushing the envelope.
Well, this is an exciting space, Mark. I appreciate you giving me the update. It's exciting to see how you're helping specialty clinics really upgrade into 2023, and this whole world of obesity medications is going to be one that we're going to watch really closely over the next few years.
Yeah,
so I'm glad to
absolutely.
know that you're working on it, and that Cecelia Health is in the middle of it. So
Yeah.
I appreciate your time.
All right, fantastic. Thanks,
All right.
Logan.
Thanks, Mark.